Hello, my name's Rachel Jones. I'm a certified industrial hygienist and professor at the University of California, Los Angeles, Fielding School of Public Health. Welcome to Module 2, Foundational Principles of Health Hazard Evaluation. In Part 2 of this module, I will discuss general approaches to the use of health hazard evaluation data to set occupational exposure limits, or OELs. It is important that industrial hygienists and other occupational health professionals be familiar with how occupational exposure limits are set so that they understand their limitations, and in particular, why occupational exposure limits do not protect all workers from all health outcomes. The learning objectives of Module 2 are to find relevant, credible sources of chemical hazard information, to differentiate among information source types, and to analyze strengths and limitations of sources of information. Occupational exposure limits, or OELs, are limits for exposures intended to protect most workers from adverse health effects. And it's critical that industrial hygienists and occupational health professionals not mistake compliance with an OEL as meaning there are no health risks in the workplace. OELs do not separate safe from unsafe conditions. For example, following an opinion from the U.S. Supreme Court resulting from litigation over the benzene permissible exposure limit, OSHA has used a risk level of 1 case of cancer per 1,000 workers exposed to the chemical over the working lifetime to set permissible exposure limits for carcinogens. This means that some workers are likely to get cancer, even though exposures at their workplace were below the permissible exposure limit. The general process of setting an occupational exposure limit involves 3 primary steps. First, one must identify a point of departure, which is an exposure level associated with a health outcome of interest. This is usually obtained from a toxicological or epidemiologic study. Second, one must extrapolate the dose at this point of departure to a lower dose or exposure level that is expected to cause an acceptable level of risk of adverse health outcomes among workers. And third, depending upon the source of the point of departure, one may need to convert the extrapolated dose to units of the exposure limit. I will give some more information about each of these steps, but to get a more specific understanding of how this is implemented by organizations that set OELs, it's helpful to read their documents. For example, the preambles to OSHA rulemakings for permissible exposure limits include lengthy, detailed descriptions about how the PEL was derived. And for the ACGIH threshold limit values, the TLV documentation describes this process qualitatively, but will identify the health outcome that is the basis and the study that is the basis for the point of departure. The point of departure is typically the no observed effect level, the no observed adverse effect level, the lowest observed effect level, or the lowest observed adverse effect level that was seen in a study with experimental animals or in an epidemiologic study. By choosing the lowest dose level for all of the health effects of interest, the intent is that the OEL will be capable of protecting workers against all critical effects. For example, if you have a study where the lowest dose to produce the health effect of nasal irritation is 100 parts per million, and the lowest dose to produce the health effect of increased bilirubin is 1,000 part per million, then 100 parts per million will likely be selected as the point of departure. When the health outcome at the point of departure is something other than cancer, uncertainty factors are used to extrapolate from the point of departure to a lower dose thought to protect against the health effect. Traditionally, uncertainty factors are either 3 or 10. The number of uncertainty factors used depends upon the relevance of the point of departure to the goal of setting OELs for people that protect them from illness. Factors that may lead to the selection of one or more uncertainty factors include using the lowest observed dose rather than the no observed effect level as the point of departure, interspecies extrapolation, which seeks to account for differences in the biology between humans and experimental animals, intraspecies variation, which accounts for the differences in how individuals respond to the exposure and develop disease. And finally, severity of the health outcome, where it's better to protect workers from very severe health outcomes by adding additional uncertainty into the extrapolation. Going back to our example of a study that observed nasal irritation at exposures of 100 parts per million, Given that the health effect was observed at 100 part per million, an uncertainty factor of 10 may be applied to count for this being the lowest observed effect level rather than the no observed effect level. And if this study had been done in mice, another uncertainty factor of 10 may be applied to account for differences between mice and humans. This gives us a total uncertainty factor of 100. That's 10 times 10. And if we apply this to the point of departure dose, 100 parts per million, we would get an extrapolated dose of 1 ppm. That is, 100 parts per million divided by 100 is 1 parts per million. The extrapolation of doses for cancer outcomes is more complicated and depends upon the shape of the dose-response curve. When the curve is nonlinear, the approach used is similar to that for non-cancer outcomes. The U.S. Environmental Protection Agency, for example, will apply uncertainty factors to extrapolate to a reference concentration for a carcinogen that has a nonlinear response. When the curve is linear, the approach used by the U.S. Environmental Protection Agency is to calculate a slope factor that determines the increased risk of cancer per 1 milligram per kilogram of body weight per day increase in dose. Describing the details of these calculations is beyond the scope of this course, and for more information, I suggest reviewing materials from the U.S. Environmental Protection Agency that are referenced at the end of this module. After the extrapolation, the dose may need to be converted into units relevant to an OEL. For example, many OELs are 8-hour time-weighted average chemical concentrations in air. But the point of departure may have involved chemical ingestion rather than inhalation, or may have involved a mouse instead of a person. Adjustments that are often made for exposure unit conversion include accounting for exposure durations. This can occur when the daily inhalation exposure in the experiment was of 2-hour duration instead of the 8-hour duration of a workday. The exposure route may also be a factor, where we are required to convert the ingested or injected chemical mass into an equivalent cumulative exposure through the inhalation route. And finally, interspecies differences arise because of a variety of biological differences, and there are different ways that these are accounted for in the conversion. Some things that might be accounted for include the surface-to-weight ratios of animals to humans, different breathing rates of the different species, or other metabolic processes. For many of the interspecies differences, the dose conversions are based on empirical models. This slide shows an equation that has been developed to account for the relative weights of experimental animals and humans, where the exponential factor of 1 minus 0.67 is empirically derived of studies using a variety of chemicals in animal species. OELs are exposure limits, but they're also typically accompanied by notations that provide additional information about health effects or exposure routes. Carcinogenicity notations summarize the evidence that a chemical is carcinogenic, while the American Conference of Governmental Industrial Hygienists and OSHA make their own classifications of carcinogenicity that accompany their exposure limits. OELs may be accompanied by classifications from the International Agency for Research on Cancer and other organizations. Industrial hygienists should prioritize eliminating or significantly reducing exposures notated as carcinogens, owing to the significance of their health impacts. Skin notations indicate that significant levels of exposure can occur through dermal absorption in addition to or instead of exposure through inhalation. Industrial hygienists should recognize that dermal protection, such as gloves and other impermeable body coverings, may be required for chemicals with a skin notation. Ototoxicity is a relatively new notation that is used to indicate the chemical may affect hearing, in addition to or in synergy with chemical exposures. For ototoxic chemicals, industrial hygienists should make an effort to reduce noise exposures and monitor for hearing loss in addition to reducing chemical exposures. Sensitization is a notation indicating that some workers can become sensitized to the chemical and have severe responses to very low levels of exposure in the future. Industrial hygienists should prioritize eliminating or significantly reducing exposures to sensitizers, owing the significance of their health impacts and the negative impact they can have on quality of life. As has been described in this module, OELs originate with observations about one or more health effects, which are the basis for setting the OEL. The OEL is intended to prevent these and possibly other health effects among workers. One or more key studies, typically experiments involving animals or epidemiologic studies, are used to establish the point of departure. That is, an exposure level where the health basis is observed, but it may also be an exposure level above which the health basis is observed. From this point of departure, uncertainty factors and other analyses are used to extrapolate to the OEL. In this module, I've attempted to provide information about the process of setting OELs while highlighting the complexity and the uncertainties that go into this process. It should be clear that while organizations that set OELs seek to prevent ill health among workers, compliance with an OEL cannot ensure that no worker will ever become ill. That is, the OEL does not define safe conditions. An industrial hygienist should have the goal of minimizing chemical exposures, not simply complying with an OEL.